lot of our people are still rolling in, including our Stanford host. We have a lot of physicians in the room that are getting paged, including our wonderful co-chair cardiologist, Evelyn Stock. And do you need to take that page, Evelyn?
No.
Okay.
Thank you. I just put them down.
So I realize that some of the folks here are new, and some of you have been with us for all 5 of our Stanford-based University of Best Practices that started here in November. But this is the 4th regional community that we've started in California, the first of which was in San Diego with Bob Kaplan's wonderful grant writing skills that got us an NIH grant. And what you have in your packets shows that there have been a couple of articles written about the progress we made by very intensively applying the triangle of policy interventions to control LDL cholesterol to 100, blood pressure 140/90, hemoglobin A1C less than 8. Very modest targets had a very big impact, or is associated with a 22% decline over 6 years in acute myocardial infarction hospitalizations. And there are many other data points that we have not yet analyzed, and I think Bob Kaplan will be working with Rand further on that. But the point is, by doing some very old-fashioned things well, we can keep a lot more families together, have happier outcomes, and save a lot of money. So that first project was associated also with saving $86 million. And the estimate from Rand was that if that had been spread across the state, the level of performance that we achieved in San Diego, it would have saved $935 million, just shy of $1 billion over 6 years. So we have wonderful data in your packets that we can possibly refer to later. But I'd like to just apologize for Nirali Vora, who will be rolling in a little bit late. She's dealing with patients right now. And I'm thrilled to hand the microphone to Evelyn Stock to give a little bit more context about what we've been doing in this exciting moment in history.
Thank you, Hattie. Thank you, everybody, for being here. As Hattie mentioned, this is our 5th meeting, and I want to recap a bit why we're here, or at least why I'm here, and the exciting time that and opportunities that we have. So far we have accomplished being here to improve patient outcomes. We have evidence that there are new treatments that are coming out that are much more effective for cardiovascular prevention. So we have treatments that are already approved and have reduced prices and are still underutilized for cardiovascular prevention. Statins, ezetimibe, and other drugs are readily available for us to take them and use them on our patients, and they're highly effective. The second thing that I want to emphasize today is that we have the opportunity to give our patients better risk prediction. There's markers such as CRP, Lp(a), and coronary calcium scores that are becoming more and more available. I am using them more and more in the clinic, and I am being able to tell the individual patient what their risk is, or if they can be better reassured that they're doing the right thing, that their calcium scans are 0 under the current treatment, and maybe we can even reduce our medications. I don't like that. As a preventive cardiologist, for me, the best treatment is prevention. So when I get a coronary calcium score of 0, I say, great, keep doing what you're doing. We're on the right track, okay? And the third thing that is important to me today to give you a message that currently new therapies are coming out. And we're not going to only be asked to step up to the plate and get to the minimal guidelines like no child or no patient left behind kind of thing, like treat the hypertension, treat the diabetes. But as cardiologists right now, we're being asked by the American College of Cardiology to tap into our ability to prescribe these diabetes medications, right? There's new evidence that the sodium glucose co-transporter medications and the glucagon-like peptide medications save lives. So our diabetic patients with cardiovascular disease should consider being on these medications. 30% of risk reduction for major cardiovascular events is something that we cannot ignore. And I know that it's going to be tough to ask cardiologists to prescribe diabetic drugs when I see these patients in clinic and I call, the primary care and I say, okay, I have your patient here, he's had heart failure admissions, he's at risk for more admissions. We know that these drugs reduce the risk of readmissions and events. What do you think that we start them on? And they say, maybe we should talk to the diabetologist or the endocrinologist. But right now, I think we're moving from a glucocentric perspective to a cardiovascular perspective for our patients. So these are diabetics with cardiovascular disease that we need to address as cardiologists. We're going to need to extend from our comfort zones. And there are guidelines out there. So the American College of Cardiology in November of 2018 released these new guidelines. They're very well written. They tell you how to do it, which patients should be on these medications. So I encourage you to reach out and do these new life-saving therapies. And I think it's an exciting time.
We want to go around the table and introduce ourselves and what excites us about being here.
I'm Joe Skye, and I'm the Chief of Cardiology at Travis Air Force Base. And I'm surprised, Robert Kaplan, I'm going to ask you to autograph your book. And I would encourage everybody here to read it. What excites me about this meeting is to be able to meet and learn from people that have been doing this for a long time, and it's a mentorship for me.
My name is Chhavi Mehta. I'm an internist at Palo Alto Medical Foundation, and I'm a new member to this group. I would say this is my second time, and what excites me being here is just the learning that I get from here. There's a lot of people with such a vast knowledge about cardiovascular disease prevention or diabetes prevention, and it's a great opportunity to learn. Thank you.
Good afternoon, Ed Yu here, family physician. I'm the Chief Quality Officer at Palo Alto Medical Foundation. I'm excited to be here because I'm going to share our story with you and also really appreciate forums like these so we get the chance to connect on a specific topic and value all the different perspectives. And I believe it's very interesting you told the story about cardiologists going into leveraging diabetes medication, so that links a little bit to what we're going to talk about with Chhavi, hoping to touch upon. And I think it's these ideas, how we cross-pollinate. Our talk will be talking about our implementation approach, and I think it's very apt to have a forum like this where we can share ideas and learn from each other. Thank you.
Hi everyone, Michelle Trevino. I'm a medical science liaison with Amarin Pharma, and this is my first time with this group. And I've attended Hattie's Los Angeles group, and I'm just really excited to be here. And I echo my colleague, everyone else here, in that I'm just interested in hearing the different perspectives of these experts here, and such a timely topic in cardiovascular disease prevention.
Hi, I'm Jim Adams. I'm from Marin County. I'm an integrative cardiologist, I guess you could say, but I've followed traditional cardiology for years and boarded in lipidology and did some of the first early work with calcium scanning and CT scanning, and did board review courses for that and so on. But apropos what you're saying, I've been doing a lot of testing in diabetics and looking at insulin levels and other kinds of things, and putting people on early therapy, Jardians and a lot of metformin and things, and send them back to their doctors, and the GPs, oh, you don't need this, and invariably so. What's a cardiologist treating diabetes for? And they sort of the diabetologist or the endocrinologist, and they don't understand it, they just don't get it. So it's, as much as it's diagnosis, it's the diagnosis and treatment. And I think it's more than just finding out what you have a positive calcium scan. It's what causes it, and how do you treat it, and how do you track it, and how do you get rid of it.
Hi, Tatiana Kent-Daly. I'm the founder and CEO of Open Health Network. I'm probably the only non-MD in the room, but we work with quite a few very well-known healthcare organizations across many diseases. And one of our customers that we've been working with for a while is American Heart Association, and I presented last time what they have done. Now they're adding high cholesterol and some other content and features on the same framework. So hopefully pretty soon I can update you on that. And this, we are not an app, we're just a tool set that enables people to create what they want, and we act as advisors. And I see patterns on patient adoptions and of different solutions across many digital channels, integrated with lifestyle and everything else. I kind of see patterns, and then when we work with our clients, we basically help them to design something that actually used by people and brings value. And I learned tons of stuff. So as a result of meeting last month, I went and I did my heart scan.
And what did you learn?
You know.
Something very
Yes, yeah, and I'm trying to get the next appointment. Well, I have family history of my dad has everything you can think of on cardiovascular, so I definitely have some good genes. So yeah, I'll have to deal with that. Thank you.
Hi everyone, my name is Louisa Dorian. I'm a practicing endocrinologist in the East Bay with John Muir Health clinics in San Ramon and Pleasanton, and actually came across RightCare through my role as vice chair for the American Diabetes Association Community Leadership Board of Northern California, and really excited to be a part of this initiative. I can tell you, after 6 years of full-time practice out of fellowship, I was starting to get a bit jaded from what I was seeing in the community with sort of the lack of proactive care for preventative measures. I think we've become more of a reactive medical society as opposed to a proactive medical society, and also a bit jaded by just the emphasis on billing and going for those procedures that obviously bring in more revenues for big health organizations, and just really appreciate Patty's initiative here, because I think I initially wanted to go into medical school to be an OB/GYN, but after my clinical rotations and seeing so many folks hospitalized for diabetic complications, heart attacks, strokes, amputations, blindness, thought I need to be an endocrinologist. So certainly echo Dr. Stock's emphasis on we need to do more to prevent a lot of conditions that can be prevented, and we have lots of effective therapeutics. It's a really exciting time to be practicing medicine.
Yes, I'm Lynn Trine with TryNoMix, and I too am here excited about the learning. I'm not a doctor, I'm not in the health profession, but I do help with TryNoMix, it is. So there is one thing now that this Dr. Kaplan's book is going around, and I was reading the back page. There is something I have to learn there, and that's the answer to the question, why do we spend so much money on health and not get such good results? So there's always exciting things to learn, and I do want to see more about that.
So Bob Trine, also with TryNoMix, and to the cost theme, I'm motivated by the by what the CDC says, that 75% of the money that's spent on healthcare in the US, 2.5 trillion with a T, is spent on treating preventable diseases. So that impresses me. And also, what Hattie and the team has been doing for the last 4 or 5 years that I've been aware of it, just to reduce the incidence and impact of heart disease. So we're focused on prediction, prevention, and detection, literally the beginning of things.
And I should just say that Bob Trine works with me and Lynn in our Los Angeles group, and I really appreciate that. He's contracting with LA County.
Hi, I'm Jeff Loy. I'm with the Santa Clara County Public Health Department. I do diabetes prevention work. A few of the projects we have going on right now, we're wrapping up our strategic plan. We're developing our new 3-year strategic plan, and we're also organizing for a symposium in August around social determinants of health. And I'm looking forward to talking with people in the room.
Hi, I'm Claudine Wu. I'm trained as an epidemiologist and clinical trials methodologist, and I'm here with the RightCare initiative, thanks to Hattie, and also working with Dr. Susan Ivey.
Carlin Long, I'm at the Prevention Center at UCSF. Very motivated to try to prevent disease, not just treat things after the horse is out of the barn. I think it's sobering, though, to know that even somebody who gets admitted to the hospital with a bona fide heart attack and gets put on all the right therapies is only about a third of them are still taking all of their therapies at the end of a year. And they've had an event. So that says a little something about the work we need to do with education.
Hi, I'm Carl Tepp from the Santa Clara County IPA. This is my first visit here. I've been to some Sacramento meetings a few years back. So thank you, Poonam, for incentivizing me to get here. Santa Clara County IPA is a true IPA with 850 physicians. And we are not proud. We're this small bar down here at the bottom that says 11% controlling hypertension. I'm pretty certain that's not, there's some documentation issues there, but I am also certain that there are big time opportunities. And I think what I can learn, I really am excited to hear exactly what you all have discussed going around this room, but also there are challenges that IPAs have that integrated medical groups do not, or staff model medical groups, or medical groups that are on the same EMR. 50% of our doctors are still on paper, and they are on a host of electronic health records, so that becomes very, very challenging. I was at Hill Physicians before this. We had the same issue, larger group, the same issues. So I'm learning and trying to get a better handle on how we can, corral all these docs to do that. Well, they want to do the right thing, but I think it's very difficult, very challenging to do so. So, thank you.
Hi, I'm Arthi Prabhakar, and it's my first time, thanks to Bob and to Hattie for the chance to join all of you. I had been director of the Defense Advanced Research Projects Agency in the Defense Department 2012 to 17, after which my husband and I moved home to Palo Alto. It's especially nice of you to hold this meeting walking distance from my home. Thank you very much. Like, how awesome is that? I am with a co-founder starting a new nonprofit organization, working title Center for Changing Possible. Our goal is to run development and demonstration programs, so R&D to do new approaches to solve seemingly intractable societal problems. And one that we are very interested in is preventing chronic disease. And so I came here today to learn, and I think I'm going to learn a lot.
Hi, I'm Bob Kaplan. I'm a health services researcher, and I was actually involved with the RightCare initiative pretty close to the beginning, not the very beginning, but pretty close to that. And then I took a 6-year hiatus running it with the NIH and the Agency for Healthcare Research and Quality. And I always like to say, when I come to these meetings, I always learn something really interesting. I meet interesting new people, and today I discovered that Jim Adams and I grew up surfing on the same beach.
Oh, surfing on the same beach, now that's a small world.
Hi everyone, sorry I was late. I came down from my clinic, which is upstairs, where I'm a stroke neurologist. But part of what I do in my clinic is secondary prevention, sort of after the patients already have a stroke. But through this group, I've been inspired to think about how we can innovate actually from the neurology and stroke advocacy side on primary prevention and get more involved in people, many of you who may have had scans or things, patients that have had scans that suggest a cerebrovascular risk, and how can I be an actor in that model either in my clinic or out in the prevention side. So I've been very inspired with this group over the years from meeting Hattie and now started being a co-chair here. And I'm just really looking forward to collaborating with all of you to really bring Silicon Valley's preventable diseases towards zero, and I think it's possible. So I've been very inspired, and thank you all for coming. Shall we get started? So, oh, sorry.
And we have also Michelle, Jeannie, if you can bring it to Michelle next.
Okay. Jeannie Rizzuto with Johnson & Johnson. We have been and I know several of you in the room I've seen, we've been a longtime supporter of RightCare initiative back from San Diego to LA to Sacramento and here. And I like coming because I get a lot of so many original thinkers in the room, and it's a great learning curve. And then it's information that I share back into, we call it the puzzle palace, into the home office a lot of times to really see, to be viewed more as a company that's helping in preventable disease, not just looking at the product, but how to be beyond that in regards to compliance, adherence, or patient engagement, and so forth. So Johnson & Johnson be viewed more as a healthcare company and not a manufacturer.
Thank you. Good afternoon. My name is Michelle Liu. I'm the CEO of the Health Trust. We are a nonprofit operating foundation focused on building health equity in Silicon Valley. And we do that by providing an array of direct services, including Meals on Wheels and case management for people living with HIV/AIDS. We do that through grant making in Santa Clara County, and then we at least aspire to do it through policy advocacy. I'm delighted to join you today and learn a lot. Thanks.
Oh, hi. Sorry I'm late. My name is Matthew Palomic. I'm a retired nuclear engineer, and I'm here, invitation by Hattie, and just to get as much information as I can on atrial fibrillation and how it may affect me, because I suffer from that.
So we're so thrilled to have some patient advocates among us, including rocket scientist Matthew Palomic. Thank you for making your way here.
So again, thanks all of you. Many of you have been in the prior meetings and have been amassing information together about all the great things that are happening in prevention and how we can really integrate the evidence-driven science with technology and other methods to really implement in Silicon Valley. Some of what we've talked about is theoretical and how do we make change, but now getting more into the practical. I think it'll be great to hear from Dr. Ed Yu, who is the CQO of Palo Medical Foundation, as well as Dr. Mehta, who's the Associate Medical Director of Quality, and how they've really been able to take some of these population health ideas and translate them in the cardiovascular and stroke prevention space into practical solutions. And perhaps through our discussion and everything we've heard about more, we can push it further and get some more for ourselves to think about in our health systems.
Thank you very much. Good afternoon, everyone. On behalf of Palo Medical Foundation, thank you for this opportunity to share our story. Our talk is in 3 parts. So the first part, you're going to hear about a story about our culture, and then how do we design our interventions to be customer focused. After that, I'm going to tell you 2 stories about programs we put in place and how we bring this to life. So Chhavi's talk about our diabetes intervention, and then I'm going to come back and conclude about one of our programs that deals directly with primary prevention, strokes, and heart attack called Million Hearts. And then I have a lot of content. I already trimmed some of that out, but you have all the slides afterwards. So I'm going to go a little bit quick, but please pause me if you have any questions. After each story, we will be pausing, taking some questions for you so that we can capture them as we go along. All right, to start, a little bit about us. We are part of Sutter Health, which is a large integrated delivery system headquartered in Sacramento. 24 hospitals, 30-some ASCs, 12,000 physicians, blah, blah, blah. But the main point is that Sutter takes care of about 3 million patients in Northern California. Our CEO likes to say we take care of 1% of the US population. So we do look at this from a population health perspective of how we do things. We are Palo Alto Medical Foundation here, headquartered in Mountain View. We take care of 1 million of the 3 million patients that belong to Sutter. So 1/3, we're the largest foundation within that. So 1/3 of the patients are come to us, call them our medical home, and we're very proud of that. And one of our calling cards is that we maintain strong relationships to our patients, and you'll see that as we go along on that. And part of our challenge, as Nellie mentioned about, is it's easy to do this on an individual patient basis, but then you have 1 million patients when you're responsible for the complexity of that and the variation that exists among that patients and also among the care delivery system adds a lot of complexity to that, that often the success and failure of how you achieve those outcomes ends up being in how you deliver care, and it's all in the implementation part. And that's the story we want to bring to you today. The previous sessions, we hear about the science behind that. I think that, again, the things we're going to do are pretty basic, but it's very well established. Then why do we have suboptimal outcomes? The complexity of the practical work gets in the way. And I'm going to share a little bit about how Palo Alto Medical Foundation tries to close that gap and tries to solve that. We should bring this up because the journey here is we cannot talk about this without making a comment about the crazy environment that healthcare is in this country right now. Predominantly things are still paid by fee for service. The more you do, the more income it generates. But to do this care right, you really need to move towards an outcome-based world. You should be valued and recognized by preventing the heart attack, not by treating it or the complications that come from that. So that has been a driving theme about how we try to approach this. I have a slide in there I'm not going to show about the craziness where we are in. You saw the visual where you're in the foot in 2 canoes swimming in 2 different directions. So some of the things that we're going to share with you is that in this mixed reimbursement world, at least for us in Palo Alto Medical Foundation that we live in, how do we weave in an implementation approach that can keep us going the direction that we want while also recognize the crazy world that we're in, particularly with regards to the tension between volume and value. You're going to hear that story as well. So the next thing I want to share with you is our concept about what do customers want. So some of this work here is done about 3 years ago where we envision about, and again, you're talking to the quality guy, so I'm very data driven. We look at high quality care. Why do people come to PAMF? We know that, we hope and we recognize that we have a good reputation in the community as a high quality care place. But then again, for me, is that then how do we show that, how we prove that? So some of it on the right side of it are some of the narrative comments that we have heard from our patients about what they want. We come here because you have very experienced doctors, we know that they're well trained, they're technically superb, et cetera, et cetera. What we want to do is then, on the right side of the slide, is to pull out data that proves to show that. And that is an approach that we are pretty mindful of because, again, in a world where we're in, there has been where sometimes the most passionate voice, the loudest voice, gets all the energy in the room. And sometimes you don't balance that with quantitative or qualitative metrics to balance it out to ensure that the direction they want to go is the most valid one, the most scientifically driven one, and the most validated one. You may end up in places you don't want to be. And that's part of the approach that we have, that in our program over here, we're very deliberate at measuring measurable things to show, to kind of prove the high quality outcomes that we have. And to me, that's my obligation to the community that I serve, and also the physician that I serve, that if you say that you deliver high quality care, please prove it to me through your data. So now, based on that, I want to narrow it down here to talk about a little bit about our chronic care framework that will tie into directly to what RightCare Initiative is going to be about. Now, some of this work I'm going to pull here comes from about a decade ago. This kind of coincides with the development of the chronic care model and all that.